welcome to everybody. We're excited to have you here for our June episode of the Dementia Lecture Series, webinar series, offered by the Emory's Cognitive Neurology Clinic and Integrated Memory Care Clinic. We appreciate all of you coming. And this is sponsored by the Guazetta Alzheimer's Disease Research Center. As y'all know, and many of you have probably been here before, the social workers on the team put this together, and we base it on what y'all are interested in and the questions that we hear from y'all. And the three of us are Alice, Laura, and myself, and we're available to any of you who are in any way connected with Emory's Cognitive Neurology Clinic or IMCC. Today, we're really excited to have Lindsay Preiser with us to talk about advanced directives, why you need them and why you want them. Lindsay is a licensed clinical social worker with a doctorate in public health. She is currently the assistant professor in the Division of Geriatrics and Gerontology at Emory University. And in this position, she divides her time between Georgia MemoryNet, a macro level early dementia screening program, and the Cognitive Empowerment Program, an evidence-based day program for persons with MCI and their care partners. She earned her BSW, her Bachelor's in Social Work at Georgia State University in 2008, her MSW from University of North Carolina at Chapel Hill in 2010, and her PhD in Health Promotion and Behavior in 2016 from the University of Georgia. She has worked in numerous direct practice, research, nonprofit, and quality improvement programs to address the needs of older adults. And before recently becoming a board member, Lindsay served as the first executive director for the Georgia Pulse Collaborative, a nonprofit focused on improving end-of-life care in Georgia by promoting advanced care planning. Her research interests focus on aging, caregiving, neurodegenerative disorders, end-of-life care decision-making, palliative care, and chronic disease management. So without further ado, I'm gonna turn it over to you, Lindsay.
All right, let me go ahead and share my screen. Are you guys able to see that?
Yes.
Yeah, I am gonna just say that I did forget one little thing, Lindsay, which is that we do ask that folks hold your questions until the end. Lindsay will be available for questions, but you can use the Q&A section that you see at the bottom of your screen to go ahead and type those questions in. So please feel free to type them in throughout the session, and then we will get to them toward the end of the session. All right, sorry about that, Lindsay.
Oh, no worries. All right, great. Well, I'm so excited to be here and to be able to present, and thank you so much for the wonderful introduction. So let's start by talking a little bit about what death looks like in the US right now before we start talking about advanced care planning. So most deaths occur in older adults as opposed to younger populations, which isn't very surprising to us. While seriously ill patients spend most of their end of life at home, most deaths occur in the hospital or the nursing home. And location of death really varies regionally, with some areas of the country being as low as 35% in hospitals, and some areas like New York City with over 70% of deaths occurring in hospital settings. Quality of life at the end of life. Oftentimes we're really unprepared for the end of life, and so care might be fragmented. We tend to not treat distress until it's already occurred, when there are a lot of things that we might have been able to do earlier had conversations happened earlier. People might be receiving care from a number of different clinicians. They might be going to outpatient settings. They might have transfers between hospital settings or skilled nursing facilities. And that can cause some issues in terms of communication between settings. And then end of life often produces strains on family and the support system. Really anything that family members might have been able to tuck under the rug earlier in terms of complications or problems between one another. When we're put under stress, especially at end of life or with a serious illness, you see a lot of those interpersonal concerns come out again. And so a lot of times there are a lot of really difficult decisions that we have to make at the end of life, but if we don't have conversations about it, we're unprepared for these decisions. So let's look at some of the disparities between what people say they want to have and what actually happens in practice. 70% of patients, people who are receiving care, say that they would want to die at home. However, 70% tend to die in a hospital, a nursing home, or a long-term care facility. 82% agree that it's really important to put your wishes in writing. However, only 23% of people have actually done it. 80% say that they want to talk to their doctor about end-of-life care, but only 7% report having any end-of-life conversation with their physicians. And so there's a big difference between what we're saying we want as patients and what is actually happening in practice. And that's where advanced care planning really comes in. It's not a one-time deal. It's not something that you do and then you're done with. As our health changes, as our personalities change, our preferences might change as well. And so it's important that this is really an ongoing discussion for people, that it's something you continue to discuss as things change. You don't just want to speak to your physician about it. You want to speak to anyone who might possibly be involved in care. Someone's always going to show up that you didn't expect and have an opinion that's going to counter everybody else. So make sure that everyone who might possibly show up is involved in this series of conversations. When you've discussed your decisions, that's when you kind of come to those conclusions, and it's important to document those decisions in an advanced directive format. It's kind of a weird gift. But a lot of people that I've worked with say, we've had all of these discussions. I'm sure that they know what I want at the end of life. But if you think about your family being distressed, if you're in an emergency setting, it really helps to actually have things written out, as opposed to them having to recall those conversations that might have happened a long time ago. And then again, just because you've documented it doesn't mean that your treatment preferences might not change. And so it's a discussion that needs to continue. When does advanced care planning need to happen? It needs to happen as early as it can, and really while people are still able to actively participate in the conversation. Richard Cushing is quoted as saying, "Planning is important. It wasn't raining when Noah started the ark." So it's really important for us to have these conversations before the rain clouds are circling over the head. Get the umbrella out early. So it's important to note, and this is, part of what advanced care planning is based on, but in Georgia, a competent adult has the right to refuse any unwanted medical treatment for any reason. Otherwise, our default is to go into full life-saving mode. And so advanced care planning is really when you're looking at the types of treatments that might be given in this life-saving default, and deciding which ones you would want and which ones you wouldn't want based on what your preferences and your quality of life really is, or what you want it to be. And then, with certain pieces of advanced directives, the right to refuse or terminate treatments may be exercised by family members or loved ones in a hospital setting if you're not able to communicate for yourself. So how to have advanced care planning discussions. You want to have the discussion again, who might possibly be involved in care. Call everyone, see if your physician or your social worker is willing to do like a conference call or a Zoom meeting or anything like that to try to bring people in. You can have these conversations at home as well, and I'll provide some resources that can help you there. You know, family conflicts often surface when a person's in the hospital and people might disagree about the type of care that they should be given. The conversations can be really uncomfortable leading up to it, but the more you do them, the more you kind of personally push past these taboos. And so it's really important to consider all aspects of advanced care planning and what might affect your decisions. And really think about what is good quality of life for you, what's important for you in terms of functioning that you want to be able to do. So again, putting things in writing is so important. So not just having these conversations, but also actually documenting it. And you can update the documents as needed. We have a few different ways to document what your advanced care planning decisions might be. A durable power of attorney for healthcare form, a living will, and also guardianship pieces that I'll discuss shortly. In 2007, Georgia, originally all of these pieces of advanced care planning were very piecemeal, and Georgia decided to combine all of the tools into one document. And so in one advanced planning document with Georgia, you can name your healthcare agent or your surrogate decision maker. You can state your treatment preferences on your living will. And then you also designate your guardian. If you were to get a guardian, you can authorize organ donation, autopsy, burial, and so on. And these advanced directives are legal with the patient's signature and with 2 witnesses. All right, so the durable power of attorney for healthcare form. This piece allows you to legally choose someone to make your healthcare decisions when you can't. The person you designate might also be called like a healthcare agent. We might call them a healthcare proxy, a surrogate decision maker. There are a lot of different terms that you might hear, but it's all the same thing. It's the legal person who can make those healthcare decisions for you if you can't communicate them. What's really important to note, so the agent hopefully will use instructions and directions from your conversations and will look at your living will where you've said what you want or what you don't want at the end of life. But legally, they can make choices for you that override those decisions in the living will. So it's important to really choose this person carefully. You want someone who's going to make the decisions that you would want to make for yourself or that you trust to make those decisions. So think about it. Your wife might seem like a really good agent. She's a loud advocate. She attends all of your doctor's appointments. She knows about your healthcare conditions. However, maybe in the case of a crisis, you know that you wouldn't want any life-prolonging treatments, but you know that your wife would want to keep you alive at all costs. So even if she knows your care wishes, you don't believe that she'll actually follow them when you can no longer make those decisions for yourself. So in terms of whether or not she would be a good choice for your healthcare agent, she might not be. And these can be kind of difficult discussions that social workers can usually assist in, but it's important to think, about someone who is going to speak for you. You also need someone who's assertive. In these situations, a lot is going on. You need someone who can throw themselves in front of a gurney with your advanced directive and say, no, don't intubate them. You need someone who's going to speak back to the healthcare system. And so think about someone who's comfortable in those settings and comfortable speaking up. And then also you want someone who's available. So you don't want someone who's across the country who cannot be there if you are hospitalized for some reason. You want someone who can actually show up if they need. The living will is the section of the advanced directive that specifies the type of care you should be given in different scenarios if you can't speak for yourself. This is used as the guide for family and physicians, but it doesn't carry really any legal weight if it's challenged. So typically our medical system, if family shows up and they're saying, hey, we disagree with everything that's going on. We want different decisions made. If a living will is the only thing that was completed, that's where, there can be some pushback. If you think back on the Terry Schiavo case and how much pushback there was, the husband's trying to go by the living will and by their advance directive, family are saying other things. And so typically in those cases, the healthcare system is going to default in a life-saving situation, which is why we need to make sure that we are designating a healthcare agent who can make those decisions for us. Because if someone disagrees, we need to make sure we've got a legal advocate there. There are also some issues with living wills. So other than the fact that they can be overridden by your power of attorney, they also don't normally transfer with the patient. So not all providers are going to have access to this. They are going to require a loud advocate to ensure that your wishes are respected so that they're not overridden if people aren't really paying attention in the middle of a crisis. And then many people don't keep advance directives in accessible places. So I've had a lot of people who say, oh yeah, we did that a long time ago. We've got it in a good place. Our lawyers got it, or it's in our safety deposit box. And it keeps it really safe from your medical providers. And that means your physicians aren't going to know what you need and what you don't need. And so, we need to make sure that these documents and this information is accessible to your providers. And then again, they also don't legally mandate like a certain type of treatment. They're not physician orders. So it didn't carry the same weight as like a do not resuscitate order or something like that. It's really just more a guide. And so, there have been some issues, some holes in terms of living wills and how they work in practice. So thinking about what kinds of decisions you have to make at the end of life, there's an interesting paradox that was discovered. So when you ask people how they'd like to die, most people are going to say they want to die quickly, painlessly, peacefully, preferably in their sleep. It would be really nice if we could all just go that way. But if you ask them whether they would want different types of interventions when they're on the cusp of death and already living a low quality of life, people tend to say yes. They say yes to CPR. They say yes to ventilation. If a healthcare provider is saying, do you want us to do everything to save you? They say, of course, yes. Why would I not want to be saved? But not physicians. If you ask physicians what treatment they want at the end of life, they overwhelmingly say no. So this graph shows the answers that physicians gave when asked if they would want different types of interventions at the end of life. And in all of these cases across the board, with the exception of pain medication, doctors overwhelmingly said no. I would not want any of these invasive procedures. But that really differs from what we tend to get from patients. There's a big disparity between what physicians want and what patients say they want. And so what's the reason for that? And the real reason is because physicians know more through actually seeing it and treating it. They understand how terrible or painful or uncomfortable undergoing some of these interventions can be. A second reason has to do with the perceived effectiveness of these interventions. So I think a lot of people, we don't have a medical background to rely on when we're determining what kinds of treatments we would want or not. There's actually, I'll bring that up in the next slide, but there's a disparity. We tend to learn about medical procedures from hospital dramas and television, and that's not the most accurate way to get information. And so physicians just tend to have the actual on the ground experience in terms of knowing what works, what doesn't work, and what your quality of life is going to look like after that treatment. And that's where we need to make up this information, this education graph or gap for patients and care partners. So I want to talk about the survival rates and the quality of life for different types of interventions. And this is how I like to approach advanced care planning conversations, is making sure that you guys have the same information that we do, and you can make those calls with all of the information present. So in terms of CPR, so once I presented to a support group on advanced directives, and I started out and I asked the group, if you were in an acute health incident, would you want CPR? And a man spoke up and he said, well, of course I do. And I asked him what he thought the success rates for CPR were. And he said, probably about 99%. That's not the case. It's actually between 8.4 and 10.6%. And you know, what I mentioned earlier in terms of we get a lot of our information from medical dramas, there was actually a study of medical dramas from the 1990s, and they looked at the success rates of CPR on all of these episodes of medical dramas. And CPR on TV works about 75% of the time. 25% of the time, they still need their drama and the patient dies. But 75% of the time, they recover from CPR, and then they're discharged from the hospital looking model-esque, because we all do. So there's a big disparity between what we're seeing on TV and what the actual survival rates of CPR are. Nationally, after CPR, we have an overall survival rate to hospital discharge of between 8.4 and 10.6%. And that includes even with EMS assistance, if they're there very quickly. And this is across all ages. So it's important to note, this is including more physically robust individuals, in addition to people with poorer health functioning. And so you tend to see higher rates of CPR survival from younger individuals, and the survival rates are even lower in older cohorts. In addition to that, CPR is very, very rough on your body. It frequently leads to crushed arteries. Broken ribs are very standard and common. Those broken ribs might lacerate other organs. And so there can be a lot of damage done through CPR. People wake up and they're in pain. And if you're already physically frail, or older individuals in general, you might be more susceptible to additional damage. So if you look at this, around 8% of people who survive CPR, let's even break that down. Or actually, never mind. Oh, and I guess the last comment on this one is that survival rates after cardiac arrest at home versus in a public setting are even lower, because it takes a lot longer for someone who is trained to come in and help. So if you're in a public setting and there's someone who is able to provide CPR easily and quickly, there are higher rates of survival. At home, the survival rate after an acute incident is only 2%. So mechanical ventilation. This is a difficult one, especially with COVID, because there's so many people who are being ventilated right now. And so looking at the survival rates, I look at with COVID or without COVID in terms of mechanical ventilation. So non-COVID, usually these are persons who might have chronic obstructive pulmonary disease or some kind of lung disease where it's just more difficult to breathe. Those individuals, when I look at mechanical ventilation, you kind of look at where they are and whether or not they can be weaned off of it. And so without COVID, of the people who are intubated, 62% of them die. And only 50% of the people who survive are weaned, which means the remaining individuals are left on mechanical ventilation for the rest of their lives. With COVID, you have a 48% mortality rate in patients who are under 40, but in older patients, it's an 84% mortality rate after being ventilated. And so there's not a very big chance of being weaned off or surviving it. And what's really important with mechanical ventilation is it's painful and uncomfortable. It's breathing at a rate that your lungs are trying to fight. So patients often report memories of pain, anxiety, panic, nightmares, distress, and trouble breathing while on mechanical ventilation. They often need sedation or medication that induces paralysis to manage the discomfort and to prevent people from pulling tubes out. Restraints might be used depending on hospital policy and whether or not we've stopped it. But they might be used to prevent patients from pulling tubes out. Delirium, which is more of an acute cognitive crisis, is pretty common with individuals who go on mechanical ventilation. There were a number, I found an interesting study that interviewed people who had survived mechanical ventilation. And there were a few quotes from patients who had experienced it before. One person said, if you need it and it does a good job and it helps you, I suppose the misery is worth it. But I would offer this as a good torture for Guantanamo. Another person said, you can't take any air in or anything, so you're constantly fighting against the tube, gasping and so forth. It was probably the closest feeling to drowning that you could ever experience. So in thinking about our goals of care in terms of mechanical ventilation and what we really want people to be getting out of that, the feeling of drowning probably is not it. And so it's really important to think about your goals of care, what you want out of quality of life, and whether or not that's something that's going to work for you. Another choice that they give us is artificial nutrition and hydration. And this is an interesting one because it seems obvious. Why would we not give artificial nutrition and hydration at different points? If they're not eating or drinking, this is something that we can provide. And this is where I think we can really do a lot of good in terms of educating people, because I don't think we as a society really know what death looks like. And it starts, a natural progressive death usually starts with a person's gastric system shutting down. And so they start to refuse food and fluids naturally at the end of life. And this is really concerning for a lot of families who are watching them fail physically and are really concerned about impending death. But it's a good opportunity, again, to teach them that this is what dying looks like. So our gastric system will shut down, which means they're not hungry, they're not thirsty. But in addition to that, your body's also producing different hormones and chemicals like oxytocin. And so they're not feeling hungry and thirsty the way we might be feeling hungry and thirsty when we are. And that's really important to know, because forcing food or drink or interrupting the dying process with artificial nutrition and hydration can shut down some of those chemicals, might turn it off, might make it more uncomfortable for a person, but it's actually not leading to survival. So there's nothing to show that at the end of life, if you hook people up to tubes, that it's really going to help them. They're dying of something else. They're not dying because they're refusing food or fluids. This is just a symptom of death. And so by hooking them up at the end, it might increase intestinal drainage. It might make it more phlegmy or mucousy in their throats, or more difficult for them to breathe towards the end of life. And it kind of disrupts that natural process. And so this is an important one for us to look out for. And just to know that it's normal when a person starts to refuse food and fluids at the end. Let's see. So we talked about some of the issues with a living will and that it can be overridden. It doesn't involve any communication with your healthcare team. There are a lot of issues. And so to make up that gap, we've created another form that started in Oregon and has moved its way across the country. And fortunately, Georgia is not in last place in this. But it's called the Physician Order for Life-Sustaining Treatment. And it's essentially a document that turns your advance directive into an actionable medical order that providers can follow in your treatment. This is an order that is completed between the provider and the patient, or if the patient has a healthcare agent designated in their advance directive and they're unable to communicate, their healthcare proxy can complete one with them. But it activates this advance directive. In general, advance directives are available for anyone who's turned 18. And of course, that's what we all do on our 18th birthday is go plan out the end of life. PULSed is really more for now. An advance directive is if something happens in the future, I'm not really anticipating it, but if it does, this is what I would or would not want. A PULSed is more for people in the last year or two of life when you're getting more medically frail, and you might have a lot of transfers between long-term care, hospital, or the home setting, where you want to make sure everybody involved knows what's going on and that this order is active everywhere. This makes it so that your providers know what's going on. And it also provides protection for providers who are abiding by it. So one of the big issues in advanced care planning in general tends to be if we have those family members who come out and say that they're going to sue, medical providers are always going to default for life-saving treatment in those cases. And that's where we tend to get patient wishes overridden. And so this is where patients can make sure that their treatment preferences are honored, that their providers know about it. And they don't have that concern with liability for the healthcare system. Essentially, it's the same type of law as the do not resuscitate order, but it expands upon that to include these other advance directive decisions as well. And so again, this is for people more at the end of life. It's more if you're hoping to restrict the type of care that you would want, because again, the default, if you don't have an advance directive, they're gonna hook you up to everything and try to save your life. And you also want to make sure, someone who's lost decision-making capacity is at least completed an advance directive or a PULSed if they're at that stage. And this is just a direct comparison. So advance directives for anyone over 18, PULSed is for seriously ill at anyone at any age. Advance directives can be completed alone. You just need 2 witnesses and the patient to sign it, whereas the PULSed has to be signed by the physician and by the patient. And it's a discussion that needs to happen as well. Hopefully it's a discussion where physicians can provide all of that information on effectiveness and quality of life. And that's what we're kind of trying to push with it. And then advance directives are general instructions for future treatment, whereas PULSed, you can get really specific for current treatment. So if I have an acute health incident right now, this is what I want to happen. So this is the Georgia Pulse form. It was developed as a collaboration between the Georgia Pulse Collaborative and our Department of Public Health in 2012, and then updated in 2015. And you can get the download from georgiapulse.org. And it's made of 5 sections. So CPR, medical interventions, antibiotics, artificially administered nutrition and fluids, and then the signature section. The PULSE, like I said, it can replace a DNR order as it's more comprehensive and portable. And so it would be, instead of just completing this for a DNR, you would complete this section for CPR or allow natural death or DNR. Let me see, and that would be, yeah, just that's the parallel between those orders, but the POLST takes it down into those other different decisions that you can make. So in section A, you decide whether you want them to attempt resuscitation or to allow natural death. If you decide that you want CPR, then in all of the following sections, or in the next section, you actually have to decide for full treatment, because with CPR, you might end up needing intubation or other things in order to survive after they resuscitate you if they're able to. But in this section, you're able to really get specific on the type of interventions you would want. So you can say comfort measures only, limited additional interventions, and then there's also an additional orders section. This is one of those areas that tends to be really helpful, like for people who want to continue dialysis, but might want to limit other types of interventions that they want. And so you can be specific on that. If there are certain interventions that you would or would not want, you can complete that under the additional orders section. Antibiotics is really interesting decision, because who would want to limit antibiotics? Seems like a treatment that's available and easy, and you know, why would you not? So this is another area where I think we can talk about how people tend to die. And pneumonia is a very, very common, typical death for people. And an area where you have to decide whether we want to continue antibiotics or maybe we don't. So there are studies that show, you know, antibiotics might prolong life, but it can decrease your quality of life, especially in patients with end-stage dementia. It can lead to additional side effects depending on the route. If it's IV, that can be distressing for people as well. What is really difficult for, I think, families is the trajectory with pneumonia often is a person is, you know, doing okay. Maybe they've got a couple of conditions or a couple of issues, but not really having problems. And then they get pneumonia. And so if they can recover from this, of course, like, let's go ahead and give them antibiotics and treat it. And they recover from it, but not quite back to that baseline. And they might have some weakness or frailty or additional issues that have come out of the bout of pneumonia. And once you've had it once, you're predisposed to catch it again. And so you get pneumonia again, and you still might be able to recover. And so you might still ask for antibiotics. And it's the sort of kind of stair step down in terms of a person's functioning and ability to recover, and really their potential quality of life on the other side. And so deciding at what point you might want to restrict antibiotics, you can still treat the symptoms and make the person comfortable, but you know, you might not want to go ahead and do antibiotics if it's going to distress them. And so it's kind of that economic trade-off, and figuring out when to limit those types of things is really important for families. Artificially administered nutrition and fluids. Again, we've already talked about this. For end-stage dementia, it's not been shown to benefit patients. It's not been shown to extend the length of life beyond 12 to maybe 24 hours, if that. With the POLST, in addition to, you know, you can say yes or no, but you can also say, maybe I want a trial period to see if that'll work. So sometimes people might say, let's do a trial period of 30 days and see if that helps. One of the difficult things about that is that sometimes removing care is more difficult than not doing it in the first place. And so it can be difficult for families at the end of that 30 days to say, let's go ahead and let's go ahead and remove it, as opposed to not doing that in the first place. And so, you know, this is an important discussion for families to have. For the pulse to be active, you need a patient and the physician, or the authorized health advocate and physician. If the patient did not designate an advocate and is unable to speak for themselves, the pulse can be signed by two physicians. And usually these are cases where the person did not complete an advance directive or designate a legal proxy to make their decisions for them, but the family is asking for pulsed or for limited interventions or things like this. And so in that case, since the family can't legally sign off on it, they might request a second physician to do that. And then advanced care planning, I think, is particularly important and special in dementia care. You really need to start the conversation early. It's important for people to be involved and engaged in care. You know, autonomy loss is so difficult in the whole dementia process that you want to include them as early as possible, and just really make sure that, you know, they're understanding they're involved in those decisions as well. As the disease progresses, it's a lot more difficult for them to really consider those future preferences, but their participation is important. You would want to talk about different scenarios. And so one of the resources I'll send to you is a booklet that provides some kind of case studies that you can kind of go through. You can feel them and really think about whether or not you would want different types of treatments under different types of circumstances. You want to ask about possible situations in the future, and then ask them about their fears for their future care at the end of life. What is good quality of life for them? For some people, it might be that I'm completely pain-free, and maybe I'm taking a lot of medications and I sleep a lot of time. For some people, it might be, you know what, I want to feel well enough to go for a drive with my family. Or it might be that you just want to talk with your family. So you know, really need to figure out what's important for you at the end of life. So I'm going to send out some additional resources. The Critical Conditions Planning Guide is what I just discussed, where it goes through a number of different case studies, and you can really discuss it with family members to get a better sense, you know, more of an intuitive sense of what they would want or what they would not want, because our advance directives are pretty limited in terms of you know, these different scenarios. It's very black and white, and that's not how reality actually is. Atul Gawande's book, Being Mortal, I highly recommend, just in terms of learning about end of life in our healthcare system. And there's actually a PBS Frontline program that I think you can look up and see an episode of. And then I can send this presentation out with all of these different resources. A lot of them are conversation starters, things to help guide kind of awkward at the end of life conversations with family and friends if it's difficult. And then my references. I am available for questions if Laura is there to facilitate. So.
Thank you so much, Lindsay, for this presentation and the helpful information that you have shared. We have gotten a couple of questions that have come in through the chat, and I know this is one that I get asked frequently, and it talks about sort of what do you do with those documents that are not advance directives or pulsed? So things like the 5 wishes. This one specifically asked, which may be a different answer, about the healthcare directive for dementia that some people have filled out themselves. Is that something that you do instead of an advance directive if you have dementia? Is it an addendum? What sort of weight does it carry in a healthcare setting?
Yeah, so the advance directive for dementia, and I'll send that out as well. It's nice because it goes through kind of different stages of dementia. So you can talk about in early dementia, this is what my symptoms might look like. This is what I would want if something happened at this time. Moderate stage, this is what symptoms would like and what I would want at that time. So I believe, and I'll verify before I send out resources, but to me, that's really one that we use as kind of an addendum. It gives families more information. We have the Georgia Advanced Directive for Healthcare that's really based on like this original legal statute in Georgia. And a lot of these other directives, 5 wishes, that kind of thing, some of them are legal in some states, some of them are not legal in other states. And so I like the Advanced Directive for Dementia as an extra, if possible. It just kind of gives you more of a narrative in terms of what that person wants and what they don't want.
Thank you. That is helpful. The other question we got was around CPR. And so I think if CPR has such low positive outcomes and is potentially so risky, why are we all so encouraged to have that certification?
I know, I think that's really interesting too, to be honest. Might be the sort of thing that's kind of becoming more outdated, but there are a lot of medical protocols that were developed in the 60s and 70s that might not necessarily be the most up to date. And I think that this CPR doesn't necessarily reflect more of like the holistic perspective that we tend to take of life and death now. So, it's still life-saving. It's a good treatment. I've known people, younger people who have had CPR and who have survived it with a lot of pain and recovery. So it's important for us to have. I think still in our pockets is something that might help, but we are, I think, in general, kind of uneducated or miseducated about it. And I think we give it a lot more weight than it necessarily deserves in terms of the spectrum of treatment we can offer.
Those medical traumas have really influenced us.
I know. Give me CPR. I'm going to walk out a foot taller and hotter.
Right. And I think that you have answered this, but we got a question, so I want to make sure that it is clarified. So there's questions about who sort of executes a pulse. Do you have to go to an attorney to initiate this? Where do you get started on this document?
You don't. So you don't need an attorney for any of these advanced directive pieces. That's more on the financial side, although a lot of attorneys include it like in the entire estate package planning. PULSed is a medical order, so it's actually written up by a physician. It has to be signed by a physician in Georgia. It's helpful to have the conversation with the physician as well, so you're able to get like that direct medical information on survival rates and quality of life. That said, in practice, I think sometimes other healthcare professionals might have the pulsed conversation with the patient and family, and then the physician kind of comes in and finishes up and signs off. But that is not done through a lawyer. It has to be completed by the physician and by the patient. And then the medical order is translated into the hospital system so that they know if the patient comes, this is the medical order, these are their advanced directives, they are not going to receive this treatment.
Yeah, and so at the Integrated Memory Care Clinic, we do have pulses and fill these out on behalf of our patients. And so this is usually, sometimes the providers will initiate these conversations, but it is also perfectly appropriate for patients and families to say, we would like to have this as part of our medical record, and we can get that completed and executed for y'all as well.
Yeah.
The other question that I often get asked, and we have, I think, answered all of the current questions, but if you have more, please use the Q&A section to submit those. And Lindsay, I wanted you to speak about something that I have seen an uptick in recently. I think we've talked about this before, but assisted livings who are adding pulse to be completed as part of the move-in packet. Do you have any thoughts about that? Consider.
It's this sort of thing in skilled nursing. It's probably appropriate because usually most of those people are in the last couple of years of life. assisted living, you're not in the last year of life, so it's really not necessary. That said, I can kind of understand some of these long-term care facilities wanting it, because otherwise they would be having, like, they would have residents complete and allow natural death or DNR order. And so they're trying to be more comprehensive, and they're using the PULST instead. To be honest, like in an assisted living setting, ideally, I think it's fine for you to use the PULST, but probably just focus on that CPR A&D section as opposed to the rest of the decisions. And you can leave the rest of them blank as well. You don't have to complete the entire thing. They're only going to go by what's been completed as long as it's signed. So, that would be my preference in terms of assisted livings, if they're going to use them to make it easier. And I'm, fine with them trying to be more comprehensive. I would stick, or as a patient, I would advocate just to really stick with that top piece until you're at more of like a medically fragile place where you really want the rest of those decisions documented on a PULST form. So.
Thank you, Lindsay.
Yeah. Any other questions?
I don't see any that have come in. We'll give people a few more minutes. Alice or Ashley, do y'all have any questions that come up in your work with families?
No, I think Lindsay has covered everything quite beautifully.
Well, and please feel free to reach out, or you can, put people in touch with me if they have additional questions.
Well, Lindsay, thank you so much for your time this morning. We have really appreciated it, and we have appreciated the information that you have shared.
Thank you.
Before we wrap up, we will get Lindsay's resources out to y'all. But before we wrap up, we could not leave without at least mentioning the news that came out Monday that we have had lots of questions in clinic about. So the FDA provisionally has approved aducanumab or Aduhelm as a medication for Alzheimer's disease. And so there's been a lot of excitement and a lot of to do here at Emory and the Brain Health Center and the Alzheimer's Disease Research Center. So we are, it is an infusion drug, so it is not a medication that you would pick up from a pharmacist. It is not an injection like some of the news outlets have been performing. And so, or not performing, reporting. And so we have been working at Emory to sort of operationalize that, figure out what that plan is going to look like. Since before this announcement was made by the FDA, and now that it is live, that is becoming sort of putting things in motion around that. Emory is waiting for more guidance from CMS or Medicare, as well as from insurance payers for more information about who will be covered and approved to receive this medication. The FDA did not provide guidelines around that. And I would say at this point, what Emory knows and can share about the process is very minimal, but we are working on FAQs that will be public facing soon. So we don't have more information, but more information is coming. So you will receive that as part of this email list. So we'll make sure that everybody has that information on here as well. And with that, we will give you a few more minutes of your time back. I don't see any other questions that have come in, but thank you all for your time this afternoon, and we have enjoyed spending this hour with you. Bye, guys.
Hi, guys.